So thank you, Fiona, for joining me on this short video presentation about your quality improvement project. I know that you've been continually working on quality improvement in your service, and we thank you for actually taking the time to document some of the activities so that it can be shared with others. On the PCOC website, there's a section of quality improvement reports, and one of them that's there is this report by that Fiona Jane has led, and this report is called Identifying and Responding to Patients in the Unstable Palliative Care Phase. So I have Fiona here with me, and she's going to explain how this quality improvement project led to improved outcomes. So Fiona, I'll hand over to you to just describe a little bit about the background to this activity.
Thanks, Sabina. So Albany Community Hospice is a regional hospice that has 8 beds, and it's a specialist palliative care facility. We've been doing palliative care in our community for at least 30 years. So the background to this came from a patient outcome dashboard report in January to June, where we noticed we were not meeting the benchmark of patients being spending more time in the unstable phase. So in 2019, we didn't meet the unstable phase benchmark. So we decided to do a data dive and see why this was. So what we found looking at phase audit and a case review, we looked at 10 cases, and we saw that the phase wasn't always reassessed and changed in a timely manner, that more than 50% had complex symptoms and problems, and there were missing SAS scores, which meant patients were kept in the unstable phase unnecessarily. We also discovered in our dive that when we looked at it, the phases were incorrect, that we weren't using consistency with our reporting of PCOC language, and phases weren't reviewed every day. So what we thought we would do,
I'm just going to say the case review template and the audit tools, they are available on the PCOC website for anybody to use. So there weren't there's these resources that can be used by any service to replicate this activity.
So we then decided, how will we address this? And what we identified was there was not enough education and support for our staff. So we implemented a daily meeting, which became known and is still known as the huddle, to discuss what we were seeing from our patients in terms of their SAS and our interpretations of what we were seeing, and to better understand and allocate a phase. So we also looked at how we were handing over clinical information between shifts to incorporate our palliative care scoring. And then we made sure that each one of these handover sheets was updated just before the next shift came on, so that there was this understanding that if something had changed, it wasn't going to happen. So we modified the handover sheets to be updated before each shift, and we ensured all of our staff completed PCOC Essentials training on induction, and we're also doing it annually, just as a refresher. So we also have PCOC training and a discussion about our data in our clinical team meetings. And we've also identified champions within our team who are leading the huddles, supporting our newer staff in their understanding and role modelling the use of PCOC scoring, phase change in each huddle.
Yeah, that sounds really excellent. So your results?
So our results were, obviously, there was a 68% compliance at our daily team meetings and an 86% compliance with updating of handover sheets. And so what we saw then was our benchmark improved to 95% of patients in unstable phase for 3 days or less. And just with those simple measures of the huddle, ensuring staff education and support, and consistency of handing over information, since that time, we've always passed that benchmark. So this is one of the resources that we created to map the changes in phase, RUG ADL and Karnofsky 3 times a day with our shift changes. And as you can see, that's where that is there. So every shift, at the end of your shift before handing over, this information would be updated as well as any other relevant clinical information that was needed for each patient. And we have been measuring the compliance with this, and we've actually increased our compliance since we've put that in. It's now become embedded as just another task that we do, which is supporting us in our care.
But you also created a policy. Is this from the policy or?
So this is a guideline that supports the assessment, the PCOC assessments, and we liked the traffic light colours. I think they sort of stand out quite well, where it basically just directs care according to phase and according to our RUG ADLs. So that's also just another framework for staff to feel that they've got some guidance when they need it.
That's really excellent. Thank you so much for sharing not only your project, but the resources. They're part of the quality improvement report that's on our website. So you've made them available to any other palliative care service who would like to improve in the same way, or just take some of your learnings and apply it to their setting or embed it into their service. So thank you so much for sharing your amazing work and the work of your team, and contributing to the PCOC community. So
it's our pleasure. Thank you so much.